Dr. Grubb, thank you very much for accepting the invitation to join us at Texas Heart Institute podcast on Living Legends and Luminaries in Endovascular Medicine. Joining me today is my associate, Dr. Stephanie Coulter. Stephanie, welcome to this podcast. If you don't mind to introduce yourself.
Thanks for inviting me to participate, and I'm actually so honored to be involved today and talking with Dr. Grubb. I am actually the director of the cardiovascular training program here at Baylor St. Luke's Medical Center at Texas Heart Institute, and I founded a women's focused research collaboration, I guess almost 15 years ago, and run a busy clinical enterprise in that regard. And I'm really interested in, in selecting candidates for our program. I'm interested in what makes people tick. And for somebody to do something out of the box, they have to be, unique in some way and, enough initiative to do something different. So I'm wondering, how young were you when you decided to be a physician, and what steps did you take to get this far?
Well, thank you. I really appreciate the opportunity to speak with you today. I am honored to be part of your program. But to address your question, it's actually kind of a funny story. I'll try to keep it as short as possible.
Well, the desire to be a cardiac surgeon didn't happen till later, but my father tells a story that I started telling people that I was going to be a surgeon when I was about 3 years old. So imagine, your little 3-year-old with their pigtails running around telling people they were going to be a surgeon. Needless to say, there was a lot of laughter involved. But my father's veterinary practice was in our home, and watching him operate on animals as a child, it was pure magic, and it inspired me to want to be a surgeon. When I went to the University of Southern California for medical school, I didn't go there to be a doctor. I went there to be a surgeon, and at the time thought orthopedic surgery. But then through a series of opportunities that were afforded to me, I was able to be exposed to cardiac surgery very early in my general surgery training in Chicago, and really recognized that that is what I wanted to do. And then ended up at the University of Virginia with some tremendous mentors that then, again, gave me opportunities, and then went on to be trained in interventional cardiology at Columbia. So right place, right time was a lot of it. I wish I could say I had this master plan, and when I sat there and I figured out what I was going to do when I grew up, but some of it was just opportunity to take advantage of the door opened and I walked through it.
It sounds like you were really well prepared for a life of choosing an intellectual challenge. And it sounds like the unique childhood you had well prepared you to take chances that other people weren't as eager to take. So what led you really to choose this pathway to do endovascular interventions at this point? And it was very unusual for a cardiac surgeon to choose that path. You were clearly not worried about more lengthening of your training or, putting off living. So what made you choose that?
Yeah, I don't know that there was a big master plan when I started. I had gone to business school before I went to medical school. And so I knew that I needed to find my niche. And when I went to medical school, it was the idea to be an orthopedic surgeon, but I quickly did my research in orthopedics, and they are fantastic technicians, but there was something missing about the doctoring in that. And when I was exposed to cardiac surgery, then that was the game changer for me. But again, looking for that niche, I thought I was going to be a robotic mitral surgeon. That was the big thing then. And certainly at the University of Southern California Medical School, that was, the hot topic of what was the newest, latest, greatest. But that changed when I started hearing about the transcatheter therapies. And I'll tell a little short story, but I was interviewing at Emory, actually, and on one of the off days because I couldn't make the regular interview day. And Robert Guyton was interviewing me, and he gets called to the operating room, and he asks, "Hey, do you want to come to the OR with me?" Well, of course I want to come to the OR with Robert Guyton. And I go down, and Dr. Guyton and Thorani were doing a partner case. And I saw transcatheter valves for the first time and transcatheter aortic valve replacement. And of course, it's this huge team in the operating room, but I immediately saw that this was not going to be technology just for high risk or inoperable patients. This was going to be something eventually for everyone and for every valve. And that really sparked the desire to be an endovascular surgeon, or a hybrid surgeon even. And the opportunities at the time after training at UVA, and we did transcatheter valves there. So I had some exposure to the transcatheter therapies and certainly a lot of exposure to TAVRs and endovascular aortic therapies. But the training was team, but to really lead a heart team, I needed more. And so either go the endovascular route or the transcatheter route. And I had the opportunity to go to Columbia and train with Marty Leon and the group there. Now, Matt Williams had been the first in that group. He's, at NYU now, the first to be trained in interventional cardiology after CT surgery. And then Isaac Jors, who's still at Columbia, was the one right before me. So really unique opportunity. And I did enough PCI to be certified and checked off to do PCI. And I took STEMI call and did all of those things that a cardiologist would normally do to be certified as a interventional cardiologist. I just wouldn't go back and do the cardiology fellowship and internal medicine residency to be boarded. But the thought process, the learning about large bore access, catheter and wire skills, that really propelled my career. And so when I was able to go out on my first job, I wasn't just a member of the heart team, I could lead a heart team.
So very interesting, Deborah. But one thing that fascinated me is that your original training in cardiovascular medicine was in cardiothoracic surgery. And number one, there are not too many women that are in this field. But what was also very exciting that you pursued additional training in a fellowship in interventional cardiology. How did this happen?
Well, it's an interesting time. I think timing is everything. And it's all about the door of opportunity opening. And when it does, walk through it. So when I went to medical school, I thought I was going to be an orthopedic surgeon. I really did my research in orthopedics. But as I explored it a little bit more, there was a little bit of the doctoring missing. And I wanted a little bit more. And I didn't know at the time what type of surgeon that would be. So I went the traditional general surgery pathway. And during the course of my second year was exposed to cardiac surgery and knew pretty much immediately that's what I wanted to do is fix hearts. The impact that you could have by performing an operation to either fix a valve or do coronary bypass. Was never interested in transplant, but at the time, I really thought I was going to be a robotic mitral surgeon. That was going to be my thing. And robotic mitrals were kind of especially at the University of Southern California, that was a big deal. And so I set the course to that be my future. And I was trained in robotics and general surgery during my residency. And then went on to fellowship, as you suggested, at UVA. And about that time, that was about the same time as the partner studies were really getting going. And you can imagine that I'd gone to business school before I went to medical school, and my business brain clicked in and said, do you really want to be a robotic mitral surgeon, or do you want to get involved with this new technology of transcatheter therapies? And when you thought about just high risk or inoperable patients, you realized the technology was probably going to be for all patients and eventually for all valves. Now, if I have time to add a little interesting anecdote, when I was applying for fellowship in cardiothoracic surgery, I actually went to Emory and walked in, and Dr. Guyton had to run down and do this new procedure. And he said, hey, do you want to come to the operating room with me? And I, of course, jumped at that opportunity. I was interviewing on one of those off makeup days. So we went down to the operating room, and Dr. Guyton and Dr. Thorani were doing a TAVR as part of the partner study. And just seeing that technology, that kind of sealed the deal. So I then had to figure out, well, how can I get the skill set in order to be able to do that? Now, at the time, you could have probably just joined the team and said you're interested. But I wanted to do more. And getting back to, Stephanie, your original question, I really wanted to have this being something that defined my career, not just something that I could do. And so getting those catheter and wire skills, at the time, you had two different avenues. You could go the endovascular route. So I applied for some of the endovascular fellowships. But that was more vascular surgery-based TAVRs. And I had already had a very good experience at UVA with TAVRs and felt very comfortable with that technology. Felt like I could go out and practice, partner with vascular surgeons and really be able to treat the whole aorta and branches. But transcatheter valves were a little bit different. And, knowing that MitraClip was coming and other transcatheter technologies, I wanted to really have a different skill set. And the opportunity to train at Columbia became available, and I jumped at that opportunity. This was a little bit different than just the structural heart fellowships that we see today. I was an interventional cardiology fellow. I did more PCI than I needed to be certified, and could have gone out and become an interventional cardiologist, although not board eligible, because I would have had to done internal medicine and all of cardiology. And I wasn't really willing to invest those years. But the skill set and the language and the understanding of what you are capable of doing with catheters and wires was really what I was after. And I ended up with pretty tremendous education because of it, that then subsequently propelled my career when I went out into practice.
This is really amazing. You're truly one of a kind. I'm sure that Dr. Coulter agrees with that. And she has another burning question for you.
So during the period that you were training, it was kind of not common for women to go down this path. And so could you tell us some of the, conflicts or hazards in the way, and why were you able to persevere when it's so difficult?
Well, I think it's all, again, about the door of opportunity. And so even at UVA, they had never treated a woman before. And during the interview, I actually had the audacity to ask Irv Crone, why have you never trained a woman? And I did this in front of the entire group of applicants and then volunteered to be the first. So you have to be willing to be the first, and you have to be willing to maybe be the only woman in the room. But I actually never really felt like there were barriers. It was more about how hard I was willing to work and whether or not there would be people who were willing to be mentors, sponsors, allies, and give me the opportunities that I needed. And so lucky, right place, right time, whatever it was that put me in those situations, I was given opportunity. And whether that be at UVA to be the first woman to complete their fellowship, or the opportunity at Columbia. I was the fifth surgeon in the group that has trained under that kind of pathway, with Matt Williams being the first, who's now at NYU, and then Isaac George, who's still at Columbia, was the one right before me. So they had some experience training surgeons as interventional cardiologists, and I was just lucky that they were willing to include me in that group of people with this really specialized training.
Interesting. Since you are trained in many different areas, not just structural heart, but endovascular interventions in general, in your opinion, what are the most important contributions in the last several decades in the field of endovascular interventions?
Well, I think it's really interesting. I think the technology that immediately comes to mind because of how disruptive it has been is TAVR, of course. But TAVR wouldn't even have been thought of if it wasn't for endovascular aortic work. And so the cardiac surgeons and vascular surgeons who took on large pore access much earlier and adopted endovascular techniques, those people really laid the foundation for a lot of the work that we were subsequently able to do. I think that when we got into the valve space with endovascular techniques, that became an opportunity to really treat patients who had no options, and expand the patient population that we can serve. The dissemination of that technology and then the progression to intermediate risk and lower risk and potentially younger patients What it allows us to do is to better triage patients, because age is just a number. And sometimes you have patients that are really not very good surgical candidates, and they may or may not even be offered therapy. But with transcatheter options, you can actually better select patient for the right therapy for them to broaden your portfolio of what's offered for a specific disease process. And so, of course, TAVR was extremely disruptive. And now you're getting into mitral and tricuspid therapies, being able to treat patients who probably wouldn't have been treated at all. Especially in the mitral space, we know that there's a tremendous amount of patients who are never even sent to a surgeon because their cardiologists, or even, earlier in the process of the patient care pathway, they're just never offered therapy. They figure they're too old, they're too sick, and they think that surgery is high risk. Well, what I would say is, now that we have these therapies, the best part is that we can send these patients to a heart team and let the heart team decide. In mitral, you've got open heart surgery, you've got robotic mitral surgery, minimally invasive, you have mitral clip, and then soon to be transcatheter mitral replacement therapies. And so I think it opens the doors for patients to receive appropriate care. And what we've shown also is it's at least seems to be appropriately selecting those high-risk patients for lower risk therapies so that the surgical outcomes have actually gotten better as well. And so I think that there's a whole series of endovascular therapies that have really been game changers, but it all leads back to the vascular surgeons, cardiac surgeons treating the aortic pathologies with endovascular techniques.
Yeah, it's interesting. You mentioned something that's really dear to me, and that's large bore access and difficulties that we had to go through when we started to do TAVR procedures. As you know, in partner trial or initial trials, the vascular complications were 16% or even higher, and it's dramatically lower. It shouldn't be no more than 2%. If so, at the present time, at our institution, it's probably below 1%. And a lot of those interventionalists had to learn how to manage large bore access, which to cardiologists was a totally new experience. And of course, there were cardiothoracic surgeons assisting them, but again, the devices were not ready necessarily for large bore access. And now we have dedicated large bore access percutaneous repair devices. So that has helped tremendously, no doubt.
I agree. I mean, I think we were all learning together, and if we certainly had to leverage the knowledge of the surgeons, and the surgeons who were involved in TAVR and already had some experience with large bore access helped with the adoption of that technology. But the companies that were creating the devices, I think, also have to be credited with really innovating quickly to go from the early large bore access, we were talking about something that was quite large, to now at 14 French, where 95% of patients are eligible for transfemoral transcatheter aortic valve replacement. I mean, that's pretty remarkable in basically a decade of time. So I think that, we all learned together. I certainly remember the days of everybody getting a cut down or having to do transapical as the alternative access of choice. And I think that we quickly learned that it needs to be a percutaneous approach, and that the cut down also had its own set of complications and risks, and certainly any intrathoracic, whether it be transapical or transaortic, carried higher risk. And with innovation and with the implanters, really pushing for better technology, and then the companies listening and providing what we needed so that we could more safely complete these procedures, and then to optimize them, decrease pacemakers, decrease paravalvular leak, decrease stroke even. So I think that we have evolved so much from those large bore access days, but it's a combination of the innovation from the industry partners as well as from the physicians saying we need something better.
It's interesting that TAVR is already a 23-year-old procedure, so it's no longer in infancy, and we're still evolving technology, and there is obviously more to come, and there are still certain unmet needs that you just mentioned there as well. Well, Dr. Coulter has another very important question related to women and the SMART trial, Stephanie?
Yeah, but I wanted to ask a little bit more about what do you think are some of the virtues that go into being an inventor and a physician leader today, especially one that can, walk on both sides of the line, being in academic medicine and also being in industry, that helps us propel our field forward because we're moving forward quickly. Like I'm listening to you, and I was there as the non-invasive cardiologist. And I was wondering if you were going to mention about transapical because we did a lot in the olden days that way, and how we've moved the field forward, and we're moving the devices into ever younger populations, which actually worries me because, well, I'm on the forefront of working on those valves that have failed. So what do you think makes a virtue for an inventor or a leader in the field today?
Well, I don't necessarily think of myself as an inventor, but I've had the opportunity to work with some amazing and amazingly innovative people, and be on those teams that were able to really push the limits of technology and push out ideas that people did not react well to at first. I mean, I came just most recently from Emory, and that's kind of one of the big hubs of electrosurgery. And when you think about putting catheters and wires, the places that we've put them and burning holes in things to make a connection between the IVC and the aorta so that we can do valves on patients that don't have iliothermal access, or splitting leaflets, or, the newest sesame. It's been incredible to be part of those teams, although I can't claim that any of those innovations were mine. I think one of the things that's pretty consistent is that you have to have a spirit of how can we help this patient that's in front of me? They have no options. And we were certainly the center for no option patients. And with that, guys, how can I help? Then you can start to think about what can we do, out of the box thinking that might work. And then we, of course, had a really interesting collaboration with the NIH where we could backbench it and test it and then try it in a person under a joint IRB in a pretty rapid succession. And with that, you had to have the ability to learn from your mistakes. You had to have the ability to not consider failure as like an end point. I think somebody calls it like failing forward. I've heard that before, where you have a misstep, but you learn from it because it's not a failure as long as you learn and you can somehow take the process forward. And maybe you didn't help that very first patient, but the concept was good. And so that you could help another patient. And so when you think about some of the devices out there, I think about like early feasibility trials, or think about the very first TAVRs. If those initial patients had failed, we would not be where we are in this technology. And certainly there were other companies that came along, and especially in the mitral space, there's been lots of valves that never made it through the EFS phase. So you have to be willing to innovate. You have to be willing to be critical of your own thinking. You have to take an idea and say, okay, this is a good idea, but we didn't do it as well as we could have. What can we do better? And how can we make this work? So constantly asking those questions of yourself and your team. And I think the key point, and this gets into your question about leadership and being able to cross from being a physician to being on the other side in industry now, is really listening to the people around you, asking the critical questions. You don't always have to have the answer. I don't have to have the answer, but getting the most voices engaged, because we surround ourselves every day with really, really smart people, and asking those difficult questions and collaborating. I always like to ask the person who has not said a word what they think, because I'm a bit of an extrovert, right? So while I'm rapidly trying to think about what I'm going to say next, there's a person in the room who's not going to say anything, but they've been listening the whole time. And they oftentimes have the most pertinent piece of information to add to the discussion. And so I think that that's one of the critical things, is that critical listening.
Well, Dr. Grubb, can you tell us a little bit about the reason for the SMART trial that was recently published, and what were the results?
Sure. Well, the SMART trial, I can't claim to be part of the leadership that designed the study. But Roxana Moran, Howard Harmon, and Didier Chache are the PIs of the study. And it's sponsored by Medtronic. And the question really had to do with patients with small annuli, and in particular, women. So over 85% of the patients in the study are female. And they used a cutoff of the annulus of 450 millimeters squared. And so it's a smallish valve. So if you're talking about the sapien valve, it's going to probably be a 20 or a 23, mostly 23s. And if you're talking about the Evolut platform, then that's going to be a 23, 26, 29 in some cases. And it just has to do with the sizing matrix. They can even get a 29 in some patients with that same annular criteria. And they wanted to look at the usual endpoints of death, stroke, rehospitalization, as well as some fluidodynamic endpoints. And from the clinical hard endpoints, there was no difference at 1 year, in terms of mortality, stroke, rehospitalization. But the reality is, I wouldn't expect there to be at 1 year. I think that the hemodynamic impacts of patient prosthesis mismatch, those don't play out till later. And we've known that in the surgical literature. And if you look at the long-term follow-ups and meta-analysis, it's a problem that happens later. It's certainly something that we like to avoid in surgery and in transcatheter valve replacement. Where the biggest difference was noted is in the hemodynamics, with much lower gradients, larger EOAs with the self-expanding Evolut platform, well as lower patient prosthesis mismatch. Now, some of the other things that bore out is, traditionally thinking we thought that Evolut and any of the core valve had much higher pacemaker rates. Turns out the rates were not statistically different. We used to say that, the core valve always had perivalvular leak. It turned out that the Evolut cohort had less significant perivalvular leak than the sapien cohort. So there's some interesting things in the mix, and higher patient prosthesis mismatch with the intraannular sapien valve. Yeah,
Recording in progress.
no different. So I think that what it really shows that at 1 year, for the hard clinical endpoints, the valves are pretty similar. But there are some signals based on hemodynamics and structural valve deterioration metrics that suggest over time we could expect a difference. When that will happen, well, we'll have to let it play out. It's a 5-year trial. 2-year data will be presented later this year. I don't expect, there to be tremendous differences even at 2 years. That's just not what we've seen in the low-risk studies or in surgical. But over time, I do expect there to be a difference.
Wow, fascinating. I'd like to say, I was trying to be what you were describing, the person sitting and listening, and I'd like to make a new word for word. What you've done is that you've become part of a team of disruptors. You're disrupting industry. You're disrupting surgical practice. You're disrupting the financial models that actually go into keeping hospitals viable. And as an industry, you and Dr. Krajcer have been really part of this disruptor. And it's changing how we practice, how we think about the future. And I really want to applaud you both really for taking that role and being unafraid to say, there may be a better way to do this, and it may disrupt the practice that I'm used to being part of, but we're going to move the ball forward. And I think that's very valuable, and it's good for industry because industry leaders that take chances and disrupt can actually, win. And of course, science comes into this as well. And so being a careful scientist and looking at the data, prospectively, like you're doing, it's going to change how we evaluate and treat, women and men in the next, 20 years, especially as, these techniques have moved more and more into the community. People are putting valves in younger and younger patients, and Dr. Krajcer and I sometimes catch the opposite end of a good thing on that, being in a large medical center. But looking forward to the future of endovascular interventions, how do you think it will affect current surgical techniques and how we train the surgeons for tomorrow? Because I'm kind of worried about that.
Well, I think that it's a challenging question because I think that the way that we train surgeons is probably a little dated. And it leaves a lot of room for really being innovative and the way that we think about what counts as an operation. So, if a person stands on the other side of the table and assists, they're going to count that as a surgery. Well, I would say that using a simulator, like pilots do, and flying the plane and counting that as hours, using some type of cardiothoracic surgery simulation should count as those hours if the simulation was high fidelity. So we have to think a little bit more creatively about how we train our fellows and the quality of the experience that we're providing. I also think that, all of the surgeons should be exposed to endovascular therapies, TAVR, TAVR, the mitral therapies, tricuspid therapies, and then some of them will select to use that as their basis of their career, like I did, and some of them will go on and be transplant surgeons or VAD surgeons. But I would suspect that over time, the VAD is going to get smaller and you can also put that in on a stick. And so then, you're going to need those large bore access and endovascular skills that we talked about earlier. So I think the paradigm of how we train physicians and surgeons in particular, cardiac surgeons, has to change. It has to evolve with the technology that's available to us. Because you're right, if we just continue to rely on the way that we've trained, the residents and fellows are not going to be adequately trained to face the challenges of the surgeries that are going to be coming their way, particularly when you're talking about this new subspecialty, which is removal of transcatheter valves. I have often said that if you don't know how to put the valves in, then you're going to struggle to figure out how to put the valves out or take the valves out. The obvious example is something with a nitinol frame, right? If you had to compress it into a tube to put it into the heart, you compress it into a tube, it comes out of the heart much better. So whether that's a failed self-expanding transcatheter aortic valve or any of the mitral technologies, this is going to be a whole new animal that we're going to have to train people to be able to do. And having them be part of a heart team so they understand the technology will help them then, when the valves fail, be able to operate on those patients. Now, concurrently, we're going to have to be looking at other ways to help patients. And I think that really understanding patient's anatomy so that we choose the right procedure for the right patient up front, and make sure that we're putting the right valve in that we think is going to last the longest. And we're talking about lifetime management, really planning for, if we can, for example, for aortic stenosis, one sternotomy in their lifetime, where in that time frame does that go? So we as surgeons need to do a little bit better job of training and really thinking through not just the operation today, but in the whole scheme of things. Maybe TAVR first is right, or maybe we need to start thinking about mechanical valves more. Certainly when I trained, I didn't think I'd put in a considerable number of mechanical valves. By the time I was a few years into practice, I realized there's a large patient population that's best served with a valve that's going to last the longest. And recently at the STS, that just reaffirmed, there was a presentation there that reaffirmed what we've been saying, that for young patients, that's just the right therapy. So surgeons need to keep their seat at the table, they need to keep their skills, and we need to train surgeons in more innovative ways than we have in the past.
Well, Deb, I have one more question for you. It might be very difficult to answer. I don't know if you have a crystal ball or if at Medtronic they give you a crystal ball, but let's see, what do you think will happen 5 or 10 years from now as far as percutaneous aortic, mitral, tricuspid valve repair? Where do you see this happening? What kind of things can we expect to come in the future?
Yeah, well, I forgot to ask for my crystal ball during the onboarding process, but next time I have my annual review, I'm going to ask for that crystal ball. No, I think that you're going to see progression of the therapies that are endovascular, especially with our aging patient population. When I would sit in our valve clinic, and we would do this as a heart team, so two physicians, a interventional cardiologist and cardiac surgeon paired together, seeing the patient at the same time. These patients are not coming to the clinic saying, I want surgery. They're coming to the clinic saying, I want MitraClip, I want TAVR. And as the data accumulates on the safety and efficacy of the various transcatheter devices, then there's going to be even more justification for using those therapies as first-line therapies in a broader range of patients. So I certainly suspect that, that we'll have a device for aortic regurgitation. I certainly suspect that asymptomatic and then moderate aortic stenosis will gain approval, broadening the range of patients that are treated with these therapies. On the mitral side, I do expect that you will see transcatheter mitral replacement devices available for those patients who are not surgical candidates. And then we'll be looking at, are there groups of patients that are better served with a replacement versus M-tier? Tricuspid, I think, is a tremendous opportunity just because the bar is set so low. We as surgeons have never really tackled that patient population, and often when we did, it was at end stage, which is oftentimes too late. So I think you're going to see a tremendous number of options available for these patients. I hope that the mitral toolbox expands. And then there's a tremendous opportunity in heart failure patients, so interventional heart failure devices, whether it's shunts or ventriculoplasties or other therapies to treat heart failure patients, because these patients are miserable, and many of them they either are non-compliant with their medical therapy or they don't tolerate it. So although we know guideline-directed medical therapy works, the number of patients who are actually on the recommended 5-drug regimen is small. And so there's tremendous opportunity to treat patients who are now suffering from congestive heart failure, either from valvular heart disease or other reasons. So this whole arena of transcatheter therapies, I just think will continue to grow. There'll still always be a need for surgeons. Cardiac surgery is not going away. I still think it's a very, very interesting field with a lot of history. And we certainly need to continue to recommend heart teams for these difficult therapies. And heart teams to take care of these difficult patients, because we've pretty much demonstrated that having that collaboration has provided excellent outcomes. But that would be my crystal ball prediction. It's a little bit of hodgepodge of everything, but in short, I don't see that there is an end in sight for the opportunities to treat patients with transcatheter therapies.
Well, Deb, let's hope that this enthusiasm that you have will rub off to the executives at Medtronic, and that we'll see all those technologies available in, let's say, 4 or 5 years from now.
Yeah,
Thank you so much.
I certainly hope so.
Thanks for joining us.
And hope we can have another podcast with you. There are so many exciting and burning issues related to structural heart disease that we didn't have a chance to discuss, but we hope that we'll be able to do it in the very near future. Thank you once again for the opportunity to have this podcast recorded with you.
Oh, thank you for this opportunity, and I'd welcome the opportunity to come back and chat more.
Thank you.